Coagulation Associates, in partnership with Wake Med Health System. Anticoagulation Associates is a clinic where patients in the Wake Med Health System requiring anticoagulation therapy for various medical conditions have their labs monitored and medication therapy adjusted based on those labs. The clinic will be staffed by a hematologist that serves as medical director, a staff MD, and 7 nurse practitioners, as well as support from nursing staff and clerical support. Our EMR module will transmit lab information as well as the medication, administration records, and prescriptions written for patients seen in the clinic. The EMR module will improve efficiency and provide cost savings by eliminating the need for labs to be transmitted by fax or physical mail to the payer, decreasing the amount of time for medication approval from the payer, decreasing the number of payments for prescriptions denied due to lack of substantiating evidence, ensuring continuity of care between the anticoagulation clinic and the payer case management program by allowing access to labs drawn. So what can we do for you? Anticoagulation Associates CareStream Lab module is integrated with Wake Med Health System Enterprise EMR system. Our platform is robust and designed to submit claims electronically to Medicare and other payers. The key to our approach was to focus on engaging physicians, nurses, and other clinical leaders to develop a model system for healthcare delivery that focuses on providing the best care possible for our patients. The CareStream module can be accessed from a variety of devices, such as a PC, desktop, laptop, across the internet or LAN. This allows for multiple sites and departments to be integrated. In summary, we can improve communication between providers and labs, make it easier for providers and pharmacists, improve provider-to-provider communication, provide an electronic medication profile. We can text pop-ups for patients followed by the anticoagulation clinic, as well as for those not followed by the anticoagulation clinic. We make compliance easy. Regulatory requirements. The Stark Law prohibits physicians from referring Medicare patients to an entity with which the physician or an immediate family member has a financial relationship, and prohibits that entity from submitting claims to Medicare for services resulting from a prohibited referral. To meet requirements, any donated system must be necessary and used predominantly to create, maintain, transmit, or receive electronic health records. Meaningful use. Demonstrating meaningful use is vital for the success of care providers and for the health of our community. Included in the strategies for demonstrating meaningful use of the EHR systems is the electronic submission of reportable laboratory results. This is often referred to as electronic laboratory reporting, or ELR. A number of new requirements under meaningful use will impact labs both directly and indirectly, For providers moving on to different stages, a number of lab orders must now be entered into the EHR through computerized physician order entry systems, and they must be received electronically in a structured data format. Hospitals and physicians also must be measured by quality metrics that rely on lab data. HIPAA. Hospitals and providers are very aware of the need for compliance with HIPAA, but are not necessarily aware of all the potential vulnerabilities to protected health information. EMRs create a lot more potential for unauthorized use and disclosures because the information is much more available. The increased availability of private information may require increased vigilance by hospital leaders and employees to protect patient rights and ensure the organization remains compliant. ICD-9 coding and billing. Medicare and other insurance payers frequently audit our patient bills together with the documented orders and diagnoses written in the patient medical records to assure that only those procedures ordered are billed. Furthermore, the procedures ordered must be deemed medically necessary. That is, it is documented that the patient demonstrated signs and symptoms which justify the test ordered. Correct coding is the responsibility of the provider of diagnostic services. To ensure code accuracy, laboratories should require that individuals with technical expertise in laboratory testing review the appropriateness of codes before the claims are submitted. Implementation. The first step of moving forward with the implementation of any EMR is assessing the needs and readiness of the user. In our clinic, we have examined the readiness of the people who will use the new system, their training needs and capabilities, the technology and equipment required, and the need for new policies and procedures. So let's talk a little bit more about assessment. The assessment is also an opportunity to build a consensus, a sense of shared values for both change based on these needs. For example, clerical staff spending much of their time notifying patients of lab results and next steps. Even more time is dedicated to this process if unable to reach the payment. The new system and its users will need to collaborate, harmonize, and centralize. Appoint project champions. Next, we will need to appoint project champions and teams that include administrative leadership. Leadership commitment equals clinical engagement. Develop a written vision. Communicate an improved process and its benefits. Example, clerical staff not tied to phones all day when physician receives results they can make changes to. Patient care as needed, such as ordering new doses of anticoagulant, which is automatically sent to pharmacy and notifies the patient of the change. The vision must resonate the local needs and be owned by the clinic. A timeline must also be established and adhered to. Training and education. For the staff, initial training will take several sessions. First, we will focus on efforts of those most resistant to the change and ensure everyone has the computer skills required to operate the system. Training will start several months ahead of rollout, and each session will build upon the last. Training will be ongoing for new staff that joins the practice after the initial setup. For patients, they will be educated at their clinical visit by staff on how to access their accounts and information, the new workflow process, and given resources for assistance. Groundwork and preparation. Of course, training and education are part of this category as well, but there are other aspects of preparation to make the go live go as smoothly as possible. These include installation of new hardware, software as necessary, preloading demographic data of current patients, establishing network security and harmonization with other entities, development of new policies and procedures, grow your super user pool, plan for overstaffing for initial go live period, and IT support. Go live. This is the big day. Super user pool staffing to ensure adequate assistance during this initial period. After a week or two, fewer super users will be needed, and by week 5, they will be available on an on-call basis. Logistical support will be on site during the initial period as well. Daily huddles to review what happened the day before, lessons learned, and to preview the coming day. Ongoing assessment of knowledge gaps and technical glitches to be addressed. For implementation to be successful, the user must feel supported and have their needs met. Sustainability. There are 3 steps involved here: revise, reassign, retrain. Revise any major workflow issues, reassign roles to better meet new processes, and retrain as necessary on the new system. While this graphic shows a one-way process, many of these steps overlap and are interrelated. So we help you to plan, to do, to act, and to study. This is our implementation model. Plan. Our objectives here are to increase clinical and administrative efficiency by aggregating patient information and medical consultations into electronic records. Do. We want to educate and train staff, allow additional staff and increase patient visit times to account for staff transitions to the EHR implementation. This allows for less impact for mistakes and lag time. We also want to identify the barriers, challenges in a controlled environment with minimal patient disruption. Act. We want to implement solutions to identify problem areas, carry out the cycle that we discussed in our implementation strategy, and make modifications to implementation strategy as needed. Study. Compare patient baseline wait times, time for patients to receive labs, total patient visit times, and the number of medical transcription errors to the pilot group. We want to examine our findings and evaluate progress and measurement goals. You may be wondering, what does all this cost? Studies estimate the cost of purchasing and installing an EHR ranges from $15,000 to $70,000 per provider. The 5 main components of EHR implementation that have an impact on the cost of an ambulatory EHR. These include implementation assistance. Potential implementation assistant costs include IT contractors, attorneys, electricians, and consultant support, chart conversions, hardware network installation, and reworking your workflow design. Your local regional extension center, or REC, can help. Contact your local REC to find out if you're eligible for free or reduced price support. Training. Your organization will need to train your physicians, nurses, and office staff before and during EHR implementation. Your staff needs to understand how to use the EHR and associated hardware, and how the EHR will create new workflows for your practice. Ongoing maintenance and fees. Potential ongoing costs include hardware, software licenses, maintenance agreements, ongoing staff education, telecom fees, and IT support fees. In addition, your organization may need to hire new staff such as IT operations staff, clinical data analyst, or application analyst. Software. EHR software potential costs include interface modules, upgrades to your EHR applications. Remember, software costs vary depending on whether you select an on-site EHR deployment or an off-site EHR deployment. Hardware. Potential hardware costs may include database servers, desktop computers, tablets, laptops, printers, and scanners. You should know that the cost of an EHR can vary greatly depending on many different factors. Although there are high costs associated with implementing an EHR, these costs can be offset over time. EHRs help practices reduce the cost of providing care in many ways. The savings attributed to implementation of EHRs include reducing several paper-driven and labor-intensive tasks. HealthIT.gov states that these savings result from the following: reducing transcription costs, reducing chart pool, storage, and refiling costs, more accurate reimbursement coding with improved documentation for highly compensated codes, reduced medical errors, reduced administrative costs associated with filling out forms, billing requests, and other paperwork, minimizing claim denials and lost charges to Medicare. In addition to the cost savings previously mentioned, practices can also receive incentives from the Center for Medicare and Medicaid. These incentives are received through the HITECH Act. The Centers for Medicare and Medicaid grant an incentive payment to eligible health professionals or eligible hospitals, EPs and EHs, who can demonstrate that they have engaged in an effort to adopt, implement, or upgrade certified EHR technology. Health IT for Economic and Clinical Health Act. This is what HITECH stands for. In order to encourage widespread EHR adoption, promote innovation, and to avoid imposing excessive burden on healthcare providers, meaningful use was showcased as a phased approach. It was divided into 3 distinct stages, which spanned 2011, data capture processes, and 2015, improved outcomes. The research. Return on investment varies with each practice and EHR system. This can vary depending on the size of the EHR, number of prescribers, functions of the EHR. However, most practices receive a return on investment and profits from its use after only a few years post-implementation. Additionally, other factors such as quality of life for prescribers, ease of communication between patients and doctors, streamlining administrative tasks, improvement in physician and patient satisfaction, and overall greater efficiency has led many organizations to implement EHRs. Five-year projection of cost for an EHR system. In conclusion, we connect you, your patients, clinicians, third-party insurers. The end. And now we have come to the end of our presentation, or with the aid of the CareStream EHR model, the beginning of your future.